going to talk about things that we monitor every shift when we have a patient with a chest tube. The first thing you want to do is take a look at your Epic orders. There are two different orders for patients with a chest tube. One is the chest tube to water seal, and one is an order for the chest tube to suction, and it states 20 centimeters on the order, and that denotes suction. Again, this is our chest tube to suction with the bellows across, and then this would be a chest tube to water seal when you remove the suction source. Additional assessment parameters would be a respiratory assessment. You want to monitor the patient's respiratory status, what their breath sounds like, and make sure that they are not short of breath. Another assessment parameter that you want to is to take a look around the chest tube insertion site. You want to make sure that the chest tube is intact. You want to check for any subcutaneous emphysema. It may feel something like crackling or Rice Krispies underneath the skin. Additionally, as you can see, this is a very large tube and it's really painful. So you really want to monitor the patient's pain status. And if you think every time that they turn or that they breathe or eating, they're feeling that chest tube. So this is a very painful chest tube. Additionally, you want to look at the color and the characteristic and the quantity of the drainage coming out of the tube. Usually, if it's draining some drainage, it's going to go from a hematuria color to serosanguinous, then to a light sanguinous color. And if your patient is draining serosanguinous and then all of a sudden the drainage becomes darker, that's something that you want to notify the physicians. Also, you want to note the amount of drainage, the quantity of drainage. If your chest tube drains more than 100 cc's an hour, that is an emergent situation and needs to be reported to the physician. Additionally, monitoring for an air leak for the patient. So, as you can see with this chest tube, this is our air leak area here. And it actually graduates the air leak from a 1 to a 5. If the patient has an air leak, you are going to hear bubbling in this chest tube chamber. This denotes an air leak. Okay? This is something that you'd want to document on in Epic if the patient has an air leak. And if that patient has an air leak, you really want to determine where that air leak exists. So what you'll first start to do is take a look at the insertion site. If you put a very strong occlusive dressing across the insertion site and the air leak stops, then you know that the air leak is occurring at the insertion site. But as you can see, our air leak still exists. So I'm going to work my way down. I work my way down to the next connection, and I really reinforce this connection where the chest tube actually meets the unit, and reinforce this with a little bit more tape. Okay. And as you can see, my air leak has stopped. So I had an air leak that existed at the insertion site. If I could not get the air leak to stop, I would work my way down to the unit. Again, you really want to protect this unit. Sometimes this unit does become cracked. It gets transported a lot. It gets tipped over a lot. We don't want to see that happen, but it does happen. And in that situation, you would want to swap out the units if the air leak existed in the unit. Additionally, we do not strip these tubes if there are clots in there. So what we do, if you do find some clotting in your tubing, you want to bend over 3 3-inch segments where the clot exists, just like this, and then squeeze it 3 times. 1, 2, 3. And that should be enough to release the clot through the tubing. One more thing you want to be aware of is if there is accidental dislodgement of the tube. So your patient has accidental dislodgement. The tube comes out. So what you would do at that insertion site, you would take a sterile dressing and you would want to tape that insertion site with a vented dressing. A vented dressing means you are only taping 3 sides of the dressing. So 1, 2, 3. So you leave one side that's open. If you put a completely occlusive dressing in that area, it could actually get sucked into the lung. So you want to keep a vented dressing taped on 3 sides, and then again monitor the patient for respiratory distress. Hook them up to a pulse ox, see what their pulse ox is. And again, in the event that you would need to call an RT in that situation, you certainly can. Have someone stay with the patient, monitor their respiratory status, and call the physician at that time if the tube is dislodged.